Okay, so what I propose is, Alicia, if you can just give us a walkthrough about the
Sure.
current case that you're sharing today. And then after Alicia shares her case, we're going to have a 5 minutes where it's just questions. So, let's not provide any kind of ideas about what to do next. It's just let's try to understand every single angle about this case, and let's make sure we really understand it before proceeding to the next step. Okay, so
Sure.
Alicia, if you want to share a bit about the case that you're presenting.
Absolutely. Okay. So, and I just saw the patient tonight actually, so I have a very current like state of, where he's at. Um, so he presented to me with more significant pain than what started 18 months ago. So I'll kind of go back to then because I kind of rehashed that with him tonight. So he started with just right testicular pain that was just kind of intermittently shooting. So he thinks I think he saw the urologist first, but saw a physician within the first 4 weeks of that kind of starting. It wasn't right away, but he didn't let it go on too long. So they went with, urinalysis. He did have some blood in his urine, but no bacteria. So of course they gave him antibiotics anyway, which did not change any of his symptoms. Um, that kind of progressed to lower like left-sided as well. So then they kind of decided that they were going to do 'cause they did a few rounds of antibiotics. Unfortunately, he had C. diff a few times, which he's pretty much like, no more antibiotics for me, please, because that has made everything worse. They elected to do a tuna in November of 2022, and he said that slightly decreased the pain in his testicles, but not significantly. They just started treating the prostate. He has never had any flow issues, start stop stream issues. None of that has changed through this whole time. He doesn't have, night wakings, frequent urination. He has pain, but it's not like it's related to more of any bladder symptoms. So since the tuna, though, he now has more progressed pain through his lower abdomen. He describes it as bladder spasms. He doesn't truly get bladder urge, though. I don't really think they're truly bladder spasms so much as it's lower abdominal, um, you know, pain that feels to him like it's, either, paresthesias or spasming, but it just a lot of tension within, right above his pubic bone. Pain into the perineum. He can't really discern necessarily right or left. It seems pretty central. At this time, pain is more left-sided, right, along in his adductors, anterior thighs, up, then like suprapubic, upper on iliac crest. So now he does have this, I would say, low back pain, like almost SI, pretty low, not anything higher, but I have started going much higher up because at this point, when I look at him, I so we've done internal work, which he did respond to. He feels like it does decrease his pain at times, but his main complaints. Let me go back. So after he has sex, so he doesn't have pain with erection, no pain with ejaculation. Some pain he thinks goes to the top of the penis, nothing down to the tip of the penis, though. So we kind of figured that out tonight. I'm like, does anything really go all the way down, or does it just feel like it shoots? He describes more shooting pain into the testicles and into the scrotum as opposed to all the way down the penis. So he when he has sex, he has no pain when he's finished. Then the pain starts to build. So if it's like at night, then it starts the next day. If it's in the morning, it starts that evening. Each day subsequently gets worse. Sometimes when he's really aggravated, he says that like a full orgasm will decrease his symptoms for a while, but they do come back, but it doesn't always happen. So like 3 weeks ago, I did some spermatic cord treatment, and he was like, I had no pain for days. He felt amazing. So of course he's like, so we had sex, and he's like, it was fine. He's like, I waited another day. I decided, all right, let's do it again. So they did. It was okay. Again, no pain. After like in the course then of 6 days, the third time just kind of just stormed his whole symptoms again, and he really flared up again after that. He was tender to palpation, like right testicle. I was almost kind of like, it'd be weird if you had epididymitis, but it was just kind of up in that general region. That has subsided, so I feel like it's kind of back to baseline, but we haven't had just an amazing like change, kind of going back to that, for, gentle fascial release, like spermatic cord treatment. Now, last weekend I went higher up, like, L1, 2, T12, because I'm like, I think we need to go higher up into this, genitofemoral ilioinguinal hypogastric, scenario here. So he said, and then I was working iliacus on the left side, lateral abdominal wall, which he did note decreased pain after last week. So he said that was better. His pain overall was better through the end of last week and over the weekend. He said there was intercourse on Sunday, Monday, Tuesday were okay. Yesterday and today things were building again. Side note to all this, he has been undergoing some recent treatment for diagnosis of like psoriatic arthritis. I think I kind of mentioned that in here. He had been on a lot of steroids. When I saw him when he first came in, he was having a ton of side effects from steroids and swelling, but none of it changed his pain either. So he's on methotrexate. Now they're trying to go with that a little bit as far as the rheumatologist and whatnot, but it doesn't seem to have changed any of his presenting symptoms. So today I really looked at like psoas bilaterally. Left side was a very tender, iliacus really tender again on that left side. Right side was not. And at one point when I was palpating on the left side, we did get some referred pain all the way down to his scrotum. So I thought that was good. And he saw pain management because they were looking at doing a pudendal nerve injection. But now I'm like, I mean, it may help a little bit, but I feel like it needs to be higher. So yeah, that's kind of where I'm at right now. I'm trying to think if I touched on or anything, wrote anything else down on there. But yeah, I mean, he's getting obviously emotional and very drained and, really depressed. And I mean, I think I told him, I had, after we set all this up after I saw him last week. So when I told him today, I go, I'm going to have a lot of brains on this tonight. So I'm like, I think he just appreciates that I'm trying to like put it all together. I'm like, there is something. I'm like, there's something, but, so for no lack of effort, on our ends, I think he's at least grateful that this is going quite this far. So anyway.
Yeah. Thanks for sharing the case, Alicia, and 100%, thanks for being here today. And it really shows that you care about your patient. And I mean, we have 13 clinicians here right now at, well, it's 9 p.m. our time. So definitely, very passionate PTs trying to just learn and help patients. So we're going to give it our best shot. Before we start into the kind of questioning, because we need to ask some, we need to give people the chance to ask some more questions about the case. And you're going to feel the stream of questions directed towards you, Alicia. So that's going to come. But I think Jean had a question. What is a tuna?
Yes. So a tuna is a transurethral needle ablation of the prostate. So it's a prostate treatment for benign, for like BPH essentially, which he doesn't, he's like, I mean, I don't really have a very enlarged prostate. He's 43, 44, 43. So very on that, much on that low end for a huge prostate at this point. But I mean, I was happy the urologist at least was like, go to physical therapy. But I think he's had they're just kind of giving, just kind of that typical, like, well, let's look at your prostate. Let's do a procedure. Let's give you antibiotics. And that's kind of where he's at with the urologist.
And that's a great question, Gene, because I didn't know what was a tuna. So thanks for the explanation, Alicia. So now questioning period. So no guidance, only questions to better understand the case, because we gotta look at it from all different angles. So we're gonna take the next 5 minutes or so for just questions.
Sure. So I got the chat up here too. So no other urinary.
Alicia,
Yeah.
Alicia, sorry to interrupt. So before you answer the question, we can just read the question out loud, because of people are gonna watch it, so they can't read the question. So if you don't mind, if you could just read it before answering.
Yep. Okay, so does he have any urinary symptoms, constipation, history of trauma in the past? So no to all of those. Bowel movements are regular. No. Urgency, frequency, issues with start stop, weak stream, split stream, none of that. And no trauma either. He did not, I guess I went into even, low back history. No chronic low back pain at this time. He sits mostly for work. He walks. He manages at a industrial plant or something. So he does walk, but he's not doing any heavy labor. I would say he doesn't really have a regular exercise program as far as, lifting and cardio. He goes on walks. He does like to walk, but that's about it as far as that goes. No distress questionnaire. There was any distress questionnaires or unfortunately within my the company that I work for, in the models that we use for objective measures, they're not very friendly to our men's health patients. So I just try to kind of get that information from them, but it's not objective as far as fear avoidance and negative mood and things. I mean, as far as biopsychosocial factors, he's in a supportive relationship. He has one partner. And, as far as being physically intimate, frequently, he's like normally 3-4 times a week. So, there hasn't been, I think, there's stress on his end for his pain, but he's not getting any ill effects from his partner, whether they, are choosing to abstain or have any activity just due to his pain level. I did ask there was a question about position of sex. I did ask about that today. He said he is on top. He doesn't tolerate being on the bottom right now, more just because of the pressure on the lower abdomen gives him discomfort. But so he's on top, and was thinking kind of, spinal extension, stuff like that. So we did just touch on that tonight. I didn't go any more into that. As far as masturbation intercourse, that pain is still the same. Doesn't change it drastically. Okay, so can you expand on treatment you did for low back pain in higher up areas? So I had started doing some joint mobilization, rotation, just mobility exercises, stretching, just for psoas, low, paraspinal, just kind of stretching everything, really a lot of breath work, relaxation. And that's where I kind of last week was just my switch to let's kind of tease out this lumbar spine here a little bit more. I would say there's just general low back stiffness. No, there isn't any pain with joint mobilization PAs. He was not tolerating prone very well, but again, more just due to abdominal pain, not due to any pain in the back. Let me think of what else did I write down. So actually palpation of psoas and stuff was new today, which again, that was very tender on the left compared to the right. Okay, that looks like everything on the chat for right now that I can see. I think it did change it a bit. It says, do you think that treatment in the low back had an impact? And since I did do some of the joint mobilizations and thoracic rotations and things last week, I do think that did, give him some decrease in his symptoms. It did not resolve them, but at least a change of a lower amount of pain. He did note from last week. Any range of motion loss of lumbar thoracic spine. Like I said, I think, you know, lumbar flexion, he's got tight hamstrings. He has just general decreased lumbar segmental mobility. And then nothing like no significant stiffness thoracic spine, but I just still kind of, you know, was working like we were doing thread and needle. He's been doing cat cow stuff like that since we started. So, okay, the next question is neuromobility. So I did have him do some, I'd given him some pudendal nerve glides quite a while ago, which he had been working on. And I did some femoral nerve tensioning today, which while I would say was more significant right versus left, even though his pain is more left-sided today. It was less quad stretch in the position I had him in and more just, he described it as like tension up from like proximal thigh femur up into his abdomen. So I was kind of like, okay, that's different than the other side. So I think there's definitely some there is neural tension for sure, because I feel like even when I do any fascia, like with the inguinal canal, any lower abdominal fascia work I've done, I definitely get referred paid down the system. I just can't like pinpoint it. Okay.
Yeah, it's a lot of information to process. So do we have any other questions that we want to ask Alicia? Okay, so Sunil has a question.
Hernia or bulging when lifting? No. And no history of any, you know, childhood hernia repairs, anything like that. Has he ever had pain produced with any activities other than sex? I would say, I mean, his testicular pain didn't necessarily start after a day of, you know, the next day after any intercourse. But he will have, when it kind of goes, when his pain levels increase and then kind of go back down, it definitely is after intercourse. And it will, you know, like I said, it takes like 2-3 days to build. Then he has a couple of really bad days and then it kind of like starts to go back down again. But, you know, that baseline is not no pain. It's, you know, it's still pain. But I can't say that, you know, he'll say walking will help like calm his system down, you know, a bit, like as far as just, you know, getting things moving. But it's not like if he has a lot of prolonged sitting that increases his pain, or a lot of prolonged walking that doesn't necessarily increase his pain either. Anything remarkable with internal palpation? I would say just he had kind of just bilateral elevated tension, you know, with levator ani, pubo rectalis. But he had good, you know, response to doing breath work and just stretching for pelvic floor release. And then he did get a wand. So he has worked, you know, if he hasn't been in, so he would say that would, you know, decrease the pain again, kind of temporarily. I think it's little less than it was in the beginning, but I think, you know, that tension has improved. That's where I was kind of like initially like, well, it could be a lot of pudendal nerve getting, you know, up and through here. So I think he had some with the decreased tension that has changed a bit, but I don't think it's the main driver, you know, of his symptoms. It was less than I expected. Let me put it that way, because I feel like with most of the male patients that I have treated over the past 3 years, I would say I've done like pelvic health for 5 and I've been doing much more men's health for about 3, that when they have you know, when I do internal work and there's, you know, a significant amount of tension, and as soon as you clear that out, their symptoms respond so quickly, whether it's, you know, flow or just pain, they're like, oh my gosh, I'm peeing amazingly. Like when I do have like a patient that's like BPH and pelvic pain, it's like we get that tension down and they're like, oh, I'm great. It doesn't take very long. And then it did not have as significant of an impact on his pelvic pain symptoms as I've had with a lot of my other patients. So then did the low back pain start before or after the other symptoms? I would say after. It was not, I was kind of grilling him about that tonight. Like, have you had low back pain in the past, etc. But he had nothing that really stood out to him. Just that it has increased. Like, he kind of describes it as like that it spreads up to his, like from his groin up to around his hips and then like around to his low back. Like all of that hurts, but it's still all like sacral and around, not really lumbar. What about posture sitting, standing? I think working in flexion. So I did have him just do some positional stuff today. We sat, I had him, I'm struggling with prone extension because he just really can't tolerate laying on his stomach. It's very uncomfortable for him. So we did some seated extension stuff today. And even when I was just kind of doing some movement testing, like, all right, let's sit flexed and slumped and, extended, nothing was significantly changing his resting pain at that point. I just kind of went through that tonight a little bit with him. So I could do more with extension. But I was trying to almost get like even a little bit more thoracic flexion and extension just to see if I could influence that higher up near T12 L1 too, as opposed to lower lumbar.
Okay, so it seems like we covered, a pretty comprehensive range of questions. So Alicia, if you don't mind sharing, so can you walk us through your latest thoughts and what are going to test out during the next sessions so we can all be aligned? And then after that, let's just discuss if other people have different angles or suggestions of things to test out. Let's share that because we're here for that. So
sure. So like I said, I did a little bit more work on like psoas, iliacus, that side. So I kind of reinforced our thoracic mobility exercises again that I had given him last week. I didn't give him the femoral nerve glides tonight. I did tell him, I'm like, admittedly, I said, I think I want to have this discussion and then I'm going to talk to you after to kind of figure out what else I want to maybe add on from just doing what we did last week with his mobility as far as cat-cow, thread and needle, and continuing with his other pudendal nerve glides. Fortunately or unfortunately, I'm not going to be seeing him until after his injection, which is next week. So I also said I may have just some different ideas. I don't know this pain doctor that he is seeing. So I don't know how open he is to me being like, hey, by the way, I think it may not necessarily be this pudendal nerve. Can you check a couple other things? So I think where after I was really prepping today to talk to you guys, I just kind of keep going back to that L1 area because I feel like I can't separate out his referred pain. It follows, like all three of those nerves as they come down and around, versus just being like, trace some dermatomes and like, boom, it's that one. Like, it's just seems to be, and when I kind of look at what's, coming through, the inguinal canal, but yet still what's kind of skipping around it. He had, I think just because he had a lot of testicular pain and scrotal pain, he had really that description of his, testicles really being elevated and contracted. So when we kind of did that first treatment of the spermatic cord, he was like, oh my gosh, I like really felt like I had a lot of relief. So I'm really just kind of trying to decide, is it just more like hung up fascially or do we have something going on, higher up in the spine itself? But he hasn't seen, ortho or anything like that either, because he's just kind of been back and forth between the pain doctor and urology. So I'm the only person really looking higher up outside of the pelvis. So,
And
yeah.
I think it's great that you're doing that, Alicia. And I think right now you're having a very tricky case of a patient who is definitely, you know, losing a bit of hope and bouncing between professionals, all have different treatment ideas, different plans. So now it's about how do we, you know, push our own narrative as pelvic PTs, and how do we, you know, show him that there is value to what we're doing. So
Right.
I think right now you're saying you're going towards the upper region, like L1, because you think that it might be more centrally referred just because of all the signs that you've been seeing of the refer pain, and you cannot tease out the different elements. So I'm curious to hear about other people's, you know, opinion about that specific aspect. Do you think it's something that is more peripheral or something that is more central? And please state why, and what would you do to test to confirm that? It's a loaded question. Please don't be shy. It's a penalty-free conversation. So just share your thoughts. Is it more peripheral, central? What's going through your mind as you're yeah, Steven?
I'm gonna go unmute for
Steven,
this
you're
one.
mute.
It's probably more.
Yeah.
Yeah. Here, can you guys hear me okay?
Yes.
Okay. Yeah, so I really enjoyed Alicia's description of the whole case. It was really fun because it was really easy to follow. And I think when I first started hearing this, I was thinking more peripheral just because there was, you know, the right testicle, the left testicle. But as she kind of explained more and more, I'm thinking what could be something that causes both right and left side symptoms, that can move symptoms around all these different places. And then the sensitivity along each of those different individual nerve branches started making me think that this is more central in terms of the presentation. And then the second portion is, what would I do next, Zen, or why? Yeah. Okay. And so then I was thinking, in terms of screening, I think it would be really appropriate, and I think someone put in the comment, was looking at how do these various signs and symptoms respond now to some sort of more prolonged or sustained, repeated, really maybe more exhaustive central screening at L1, you know, T12, those upper regions, but then also looking throughout that whole spinal canal, you know, from L1 to S1.
I will say too, I'm trying to think. So he has been, I'm local in Cincinnati. He has seen, though, they did send, I can't remember who sent him to Cleveland Clinics. So I can't remember if that was for treatment for his pelvic pain, because a lot of the men that I see do end up at Cleveland Clinics and then back down in Cincinnati, or if it's from the rheumatologist because of what he's got going on. But he is seeing a neurologist coming up in the next like 2 weeks. So I was also trying to figure out, since it's somebody that's not necessarily in on his case, and I'm going to be like, I don't care what you're seeing him for. Can we please talk about his pelvic pain? Even though it's not necessarily, not that it needs to be like a spine ortho or anything, but just to get that on this, physician's radar, as far as part of, the treatment of this person, because it's clearly, it can, if I'm thinking more of that, then maybe they can at least investigate it. It doesn't have to be from a surgical perspective, but just from a diagnostic perspective.
Yeah. So what I put in the chat as a question, just to guide us a bit in the discussion, because there could be several drivers behind this pain. So I put, you know, the main 4 drivers that we usually try to tease out: the spinal, the pelvic, the neural, and tissue related. So I'm just trying to get a sense of what people think. And so far, a lot of people do think it's more, you know, central, and it's a spinal. So central meaning more spinal, and spinal with a neural, you know, increased sensitivity. So I'm gonna ask Hélène. Hélène, you say it's more central. What clues in you know, the history and the information that Alicia gave you pointed to that, and what would you do next, Hélène?
Do you hear me?
Yes.
Okay. You know, my English is not that good. I'm not happy that you're asking the question to me.
I put you under the
There's so many
spotlight,
things, but I
yeah.
think it's all around, and it's not on the bobette. It's not on the pelvis only. It's going everywhere. So I would do more like what's his name? Steven said, like more positioning, extension, and to see. I would test something, you know, with him, because it's so all around. It's hard to say I will treat that and then that. I would do more general treatment, you know, educational treatment, positioning treatment, and to see if he respond to that. I'm curious about the abdominal wall. We didn't talk about it a lot. What's happening with his, do you have tension in the abdominal wall? Is it more neural or more muscular? I don't know. Alicia?
I would say that it was funny because I'm gonna see if I can get this on my camera here. So today I pulled out my my nutter for him, and I was like, okay. So, you know, I'm showing him where all these little nerve roots are popping out of the fascia here. And he's like, yes, all those yellow spots is where it hurts. And so I was, I think as far as his abdominal wall, that's where I'm a little torn between whether it's purely just muscular or more fascial. Iliacus muscle belly is very tender. So as muscle belly was tender. But there's just a lot of tension throughout the whole side. You know, I mean, it's very, you know, he's guarded at times, obviously, because it's painful. So, so yes, I mean, I don't have a ton of visceral experience yet, but
because
just as far as
I'm thinking about your patient, you know, he have some treatments, and I think he needs to have one road, you know. Okay, we'll try this. We'll try this for 2 weeks, 1 week, and you come back, and you know, because it's hard for us now to analyze and to see what's the real problem. And sometimes it's so many things together. It's not only one thing, but we can try. I think I would try one treatment, simple treatment with him, and see what's happening with it.
Right. I think that's kind of where, you know, 4 weeks ago with kind of working like internal pelvic floor and decreasing the tension, we kind of have checked that more off the list as not a primary driver of this. And so, yeah, I will admit, like, you're catching me kind of right where my head is like taking me in a different direction. So I understand for sure what you're saying, as far as like, let's pick something different and work on that. And that is like right where I am right now. I just need to decide which is the next thing I want to go to.
And I
definitely, yeah. Go ahead.
Can I maybe? So I think what I maybe would do the next visit is, because it's a big part of it does feel like it could be high lumbar spine, and because he doesn't have really bad low back or back pain, and most of his pain is low, I would try and isolate that L1, L2 area, doing repetitive extension, but doing it not in the general McKenzie global way. I would probably try and do it using like a foam roll and try and isolate the joints. So, for example, putting the foam roll in front of his chair and extend, and then isolating which level are you doing repetitive extension, and then kind of see what that does. I don't know.
No, I like that. I agree. I think that it definitely needs to be very specific to the segment for sure.
Yeah.
So just we're all on the same page right now. What we're suggesting is it's okay, let's make it more simple. You know, let's not go in 50 different directions. Let's pick one and really thoroughly test it out. Right now, a lot of the clues point out to maybe something more central. So then right now we're teasing out what do we test in terms of central. So Sunil was suggesting that foam roller exercise and targeting really that L1, L2 joint, which is, you know, a beautiful option that we can try. I'm curious to also hear, you know, what Woody is thinking, because Woody, you've been silent for a while. So yeah, what are you thinking, Woody?
I think I agree on, you know, what Helen have been said. And also I think Sunil, that's a great idea. I think at this point, I would just give up on some of the treatment, just be focused. So rule out the spine first. If it's now spinal thing, probably the next step, just do more, you know, psychosocial, you know, that kind of addressment. So more like probably toward to a central sensitization, that kind of pelvic pain, right? So, and just add on, I think this case, because he seems has more symptoms in prolonged sitting. So I think like one good exercise to rule out the spine, I think in sitting, I would just put, you know, a soft ball, like, you know, the ball can be kind of like there is not like the basketball or volleyball is too hard, but you know, the ball you play in the swimming pool, that kind of soft ball, you know, here in Canada, it sells like $3, you know, in the Dollarama. So I tend to get them right place in their thoracolumbar junction while they sit. And then every 1 or 2 hours, I just add a bit, you know, 10 repetition of extension, try to get the end range. Right. Okay. If this is have a really have impact on the pain, I think that's probably the main driver. So either the pain get worse with the treatment, or either the pain get better with the treatment. Yeah. So, but I think probably this will have some impact, because when I go over this case, I think I have seen some similar cases in the past. So I think go to the spine first, and if it doesn't change, you know, I think the last is more holistic management, more towards to psychosocial factors, lifestyle changes. But I still see a big hope, because you have been working on some of the interventions, and seems there's lasting changes. Seems, you know, what you can do have some impact on pain. So I still hesitate to think this is just a chronic pain, you know, central sensitization, because that will be more towards to always flare up, and you cannot predict. If there's a predictability, I think we have a higher chance to turn off the pain with certain exercise. But just be more focused. I think that's the next, you know, I want to do. Yeah.
Woody, something I was thinking about too, and Alicia, something I was thinking about, and I know we were kind of chatting about it in the chat, was since the symptoms are, they tend to progress after sex, whatever intervention we do in the clinic is really challenging to actually know the effectiveness of it. So it seems like if we do choose like one route, he'll have to know, okay, so you're going to track your pain post-sex, and then you might then do another night, or, you know, that day you're going to then follow up with these interventions very consistently. And we're going to look to see how your pain spikes over 3 days. So this will give us a really clear idea. And I think hopefully if he's framed like we're tracking, we're collecting information, we're assessing, then whatever information comes out of it winds up being really beneficial for him.
Yeah,
And then hopefully, yeah, it gives him a way of then understanding how the spine is impacting his overall presentation or something like that.
Yeah, and I mean, I think he's really receptive to everything that I want to try or do. So, you know, even if I were to say, okay, we're going to do this treatment and let's, you know, give it X amount of days, even if you feel great, just hold off for another day or two. So let's see, you know, how we can make sure your symptoms are responding before we add that piece back into the puzzle of like, okay, this is definitely an aggravating activity. So don't just like you have the first day, you feel great. Okay, go for it. You know, let's give it, you know, some time. So I mean, I think he'll be very cooperative with that. So I can do that for sure.
Yeah, I think that's
Alicia, do you
very
have a
good.
copy of the sex log? Do you have a
I
copy of
don't,
that?
no, I
Okay,
don't have
so
like a
we'll
physical
send you the
copy, but we
copy.
can, okay.
Yeah.
We'll send you the copy. Yeah, Dee,
Okay.
what did you want to say?
Yeah, I think that's a very good comment when Steven said, like, you know, especially when you think about what's happening, you know, during walking and sitting, and compared to, you know, the pain actually tend to relieve a little bit during sex, but afterwards the pain gets worse. It seems like probably if you look at the spine, most likely the spine load when we started, right, in certain position.
Mhm.
So we all have experience when we have some lower back pain, when we move around, it seems the force will not accumulate in the spine and seems the symptom get better. But as soon as we static load the spine, such as prolonged sitting and prolonged standing get worse. I think that's probably what's happening. If after during the sex, because the spine is moving, the pelvic's moving, so it seems that relieve the pain. But right after, you know, we go to static position and the pain gets worse.
Yeah.
Yeah.
Yeah. So thanks for sharing that, Woody. And I think a lot of people in the chat are suggesting to do the log. And I think maybe that's something that you could try out. But I'm also thinking in terms of, because of course we have our own treatment plan, and but at the end of the day, we still gotta sell it to the patient, right? They gotta buy in. And I think one of the best way to do that is to create this kind of co-involvement in their treatment, where they really acting as also a clue gatherer. And it seems to me right now, because the symptoms, they change, they fluctuate, it's really hard to track it right now in the clinic. And currently the interventions done in the clinic, sometimes it does alleviate the pain right away and he feels great for a couple of days, but then it comes back and it seems that the internal have plateaued. But so my question towards the group is, if we are to do some more spinal screening, what kind of baselines should we look at, and or to really quantify it so that he can see, okay, there's really a change, no change, or you know, it's worse. So we want to have it more clear. So what would we track for? Yeah, I tend to ask multiple questions at once, so that probably doesn't help. But yeah, okay. So Kaya saying pain intensity and pain location. Kaya, based on the case right now, you know, what would you, or you know, based on your experience, you know, what are your usually go-to baselines for a case like this? Are you saying, you know, more towards sex position, or are you saying more towards the day-to-day? So based on this case, you know, what would you suggest? I know I'm putting everybody on the spot right now. It's not easy to think on the spot, but hey, this is a penalty-free conversation, so it doesn't really matter. Okay, look at activities. Okay, interesting. So yeah, can you say the question again? So the question is, what baselines would you measure? So if we pick like 3 baselines based on the kind of typical activities that this person is doing, what would we be measuring, and what would be what will we be comparing over and over again, just to see if there's changes over time, changes in between appointments in the clinic, and changes in between, you know, a couple of significant movements or activities during the day.
Sex.
Okay, so yeah. I don't know who was talking, but please please go ahead. Okay, maybe I misheard a sound, but so Kaya, if you want to jump in, please feel free. And Sunil said not necessarily pain if possible. So why not necessarily pain if possible? Can you share a bit of insights about that?
Yeah, I think it could be like a mental shift for him, because all he's focusing on is pain, 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 pain. And obviously his whole nervous system is upregulated. So if one can start with, because you're starting with resilience also at the same time. So start with, okay, let's look at this thing totally different. And now let's look at what can you do, what, yeah, like totally activity based, and maybe use that as his baseline to kind of bring his mind off from the pain.
Yeah, what I typically do, and I agree with Sunil then, is I look at three areas to categorize it. I'll look at symptoms, mechanics, and then function. So I really like the idea of looking at activity. So we could do a goal based off his activity log or sex log, which is how did he feel his performance in sex went. We could track pain if we wanted to, or we could just track the function itself. Like, did this feel, what percentage close to your norm was this? We could then track his symptoms, 3 days post. We can see if the height or elevation of those symptoms, not necessarily pain, it could be symptom location, it could be symptom intensity. Like, okay, maybe he didn't have symptoms in his scrotum or his testicle, but he only felt it in his, iliac crest area. Right. So all of that like pathway that he was reporting all becomes the goal as well. So right. We see if it's more widespread versus more central. He might say, oh yeah, you know what, it's just all of my scrotum this time. Sometimes if he's having symptoms with palpation, it could be like tenderness to palpation. So I had a patient with testicular pain, and he would get a sharp pain when he would touch his testicle. So then after his movements that we did with him, so we did repeated lower thoracic extension, he was able to grasp his testicle with no pain. So that was that's his chief goal. Say, I can't touch my testicle with my shorts. So those would be the ways that I would track it.
Okay, so I see that Woody said testicular mobility, which is another baseline that doesn't involve pain, to Sunil's point. So Woody, can you do you mind expanding on that? What do you mean?
Yeah, I think that if people have a testicular pain, I will regularly check, the testicular active mobility, passive mobility, and with resistive testing, and just to have a sense about the whole neuromuscular component, how it works. So, if the patient came in, there's no pain, and if I see there's actually diminished, testicular mobility, especially on the painful side, I think, while you do some movement testing and you can recheck the mobility, that can sometimes give you a good idea what you are working on. So our patient came in, he complained like, testicular pain, but there's no pain in the clinic. Whatever we try, there's just no pain at the moment. So, but when you do the examination, you can see that the testicle on the painful side is riding very high. It's just almost in, the superficial inguinal ring, like there is stuck there, And he describe, he said like, I have a pain, but sometimes I feel like my testicle gonna go into my belly. So, there is no pain with passive mobility. There's no pain with resistive testing. But after we do some repeated movement testing, and you can see gradually that side of the testicles start moving down. And while we do the breathing exercise, you can see they start regain the, the testicular mobility. So I think that can be something useful to track, in the clinic, or either ask a patient to track if patient complain about that. Yeah.
Sure.
Yeah, thanks for sharing that, Woody. So if we just summarize, the next steps, or perhaps Alicia, could you summarize what do you think you're gonna do based on certain of the suggestions? What's on your mind right now, if you don't mind sharing?
Sure. Yeah, no. I mean, like I said, I definitely like the idea of taking this higher up to the spinal level and doing more movement treatment there. And again, that's where I was kind of like, at this point, if we make it worse or we make it better, I just want to see something change, right? And so that way, that'll give me a little bit more insight into that. I do like, obviously, the tracking the sex log, and I think each, between going with the lumbar treatment and then and I think, kind of looking at that testicular mobility too, because that definitely has been an on and off complaint of his as far as retraction discomfort. So also seeing how lumbar treatment can change that down the line. I think too that changes in that would be well received by him. So, like I said, I think that he does find value in everything that we're doing, but seeing that, how the direct effect of that, I think will also just give him encouragement. At this point, I, just little steps towards, whether it does seem like it's just a decrease or increased tolerance to an activity, or even just a slight decrease in intensity of pain, will give him, just the overall sense of some change that will, kind of then step back and kind of go towards that central sensitization as well. Because as we all know, obviously it just kind of grows and grows as these symptoms continue. So I think that, that's definitely where my mind was this afternoon after I was really kind of doing more of a deep dive on him. And I explained that to him tonight as well. I was like, I really think that I want to focus on treating your back a little bit more and see how we can change this, especially with some small changes in symptoms, or decrease in intensity of pain, I should say, with his symptoms last week after treatment. So he understood that, and we just did a lot of talking tonight, kind of rehashing all of his history and whatnot. But I think that it's definitely the place to go to start, for sure.
Yeah, that's amazing to hear, Alicia, and thanks for sharing that, because obviously, you went, you helped this man through a lot already. He's still, looking to make more progress, and I think based on the discussion tonight, we think there's more progress to be made, and it seems like you were already, planning your next step. So the group has just reiterated, what you were thinking, and I think that's always great to hear. Because we're all clinicians from different areas, different places in the world. So it's good seeing that we have the same mindset, and also, where there's not a lot of pelvic PTs treating men. So, I mean, we can probably count it on our hands. So it's good that we have it. We have this kind of group to support. So I think you summarized well the actionable next steps, and it seems that you're well equipped to push the case forward. So we'd be happy to hear about any progress or the next steps after you've tried that, because we're always here to bounce ideas around. It's already almost 10. Time passes very fast when we're having those case discussion, especially when there's a lot of information. So thanks, everyone for sticking around. I know it's probably late for some of us, but it's always great to hear passionate PTs discussing cases like this. So any other kind of last comment about the case, or Alicia, anything you want to share?
Yeah, I was gonna say thank you so much. I mean, within my company within Cincinnati, there's 2 pelvic health therapists, and we do each treat men, but we just aren't quite as experienced with some of these more complex cases. And we've got patients driving, you know, from an hour away to come and see us at times because they can't find anybody to treat them. And I really enjoy, you know, treating this population because, I mean, I think we all, you know, really feel impactful in the world of pelvic health and how important it is. But I, you know, at times I do feel like I'm on a little bit of an island, you know, there's not as many resources to reach out to. So this was a really good opportunity for me as well. So I appreciate that.
Yeah, definitely 100%. Thanks for sharing, Alicia. And you know, it's such a small world, such a small community, and such a specialized niche that it's you know, sometimes we feel like we're navigating alone. But yeah, I mean, the group is always open, so feel free to share any questions. And if you have cases that you want to discuss, don't hesitate to post it, and we'll make sure to host a discussion to continue that talk. It's always a pleasure to discuss.